3 o'clock 4 minutes. So as under Indians, you know that a series of child psychiatry related lectures have been held. So today we are in a third session. So today we have our senior Dr. Preeti Jacob, madam. She is associate professor in our department. She has done her DM thesis also in management of ADHD and this ADHD related topic. So I welcome madam for the today's presentation, and madam will finish the will do the presentation for 45 to 50 minutes, and then in last 10 to 15 minutes we'll take the questions. So I think we can start, madam. Welcome, madam.
Yeah, thank you very much. Thank you for inviting me to be a part of this program. Am I audible?
Yes, madam.
Yes. Okay. I have a bit of a sore throat, so kindly pardon my voice. And if there are any doubts and questions, how will they ask these questions?
They will type in, madam. At the end, 10 to 15 minutes, we will take them one by one, madam.
Okay. All right. So please feel free to ask me any question that you think is relevant to the topic. So as Dr. Rajendra said, today we will be discussing regarding the management of externalizing spectrum disorders. Externalizing spectrum disorders, we are basically going to broadly look at attention deficit hyperactivity disorder. We're going to look at oppositional defiant disorder and conduct disorder. We won't be looking at substance use disorders, although they also form part of the spectrum, because I think that's an entirely different topic for an entirely different day. So why is it important? Why should we deal with externalizing spectrum disorders? It's important because it determines adult outcomes in such a significant manner that we have to deal with it from the get-go. There is no particular area that these disorders don't impact, from whether it impacts educational achievement, to occupational adjustment, to the fact that the child may have social adjustment related issues, to even marital adjustment, may come into conflict with the law. There is even the possibility of intergenerational transmission. That is, if a child grows up to be a father who has conduct disorder or develops a personality disorder which is decidedly antisocial or dissocial, or has substance use disorder, then there is a likelihood that that father's child also is going to have trouble. So all the more reason for us to deal with this problem in a manner that is decidedly preventive in its approach, because not being able to prevent results in long-term outcomes which are harmful not just for the child, but also for that child's family and for that child's future family is the way that we look at it. Coming to the next slide. Yeah, so this is what one of the things that I didn't mention was the fact that children who go on to have conduct disorder and in adulthood, they have a higher possibility of mental health problems. That's something that we understand as psychiatrists, but they also have a higher possibility of physical health problems, which is something that we didn't quite take into account. So it's very important, therefore, that we look at conduct disorder as a disorder that we can nip in the bud, that we can do something then and there in order to facilitate better long-term outcomes. So the outline of my presentation is essentially going to be a case that I will discuss with you. And over the course of that case, we will discuss various aspects of management. Coming to the case per se, this was a 15-year-old kid that I saw very many years ago, but I used this case over and over again because it highlights conduct disorder at its very best, which is that it is not a unidimensional disorder. So here is a 15-year-old kid, second born of two siblings from a middle socioeconomic strata here in Bangalore, was brought by the mother because he was suspended from school. He and his peer group were found to be bullying another set of children from a much lower class. There was a history of previous misdemeanors. The child was aggressive towards a classmate when he was teased, and there was also history of truancy present. This kid was also aggressive at home. He was also at one point in time caught shoplifting, but the shop owner let him go. And he had also tried smoking and occasionally did drink alcohol. So when you get a child like this, or when you get a history like this, what would be the obvious diagnosis? The obvious diagnosis would be conduct disorder, isn't it? So this doesn't require any great diagnostic capabilities. The diagnosis surely is conduct disorder. But the question that you need to ask yourself is that, are we looking at only conduct disorder? Is it only conduct disorder? Or are we looking at another set of problems which aren't as easily visible as conduct disorder, but if we don't treat those particular problems, then we are likely to end up with a more complicated conduct related problem. So the question that I said that we need to ask ourselves is this the entire story? So coming to what more do we know about this child and family? Here is a child whose father has alcohol abuse, mother had dysthymia, there was significant marital discord at home, punitive and inconsistent parenting was present. Apart from not having very good supervision at home, his parents didn't know when he came home, when he went out. There was also a family history of like I said, the family history was one where the mother had a psychological disorder, as did the dad. In terms of psychosocial risk factors, they did have a recent problem in their business, which resulted in significant financial losses. The maternal grandmother, who was the primary caretaker for this child, died 3 years prior to him presenting to the hospital. And after the grandmother's death, there was history of the child feeling sad, withdrawn, would become aggressive at that point if his demands weren't met. And the mother reported that the child also had nightmares, he had poor appetite and sleep, and all of these symptoms continued for 6 to 8 months, after which things improved. In terms of birth and developmental history, there was nothing really in the prenatal period, but the mother had postpartum depression. All of the caregiving was essentially done by the maternal grandmom. Milestones were okay, but the child had stuttering in childhood, and he continued to have stuttering at the point of consultation as well. Especially when he was terribly anxious. He also had history of hyperactivity and would have difficulty in school if he was not given one-to-one attention. Coming to the birth and developmental history, like I said, as such, there were no antenatal complaints, but temperamentally, this child was a shy kid, had difficulty staying away from the grandmom, would have often have stomach aches in early childhood and would not go to school. In his previous school was bullied and had very few friends, good friends, but very few friends. And after this financial loss that the father sustained in his business, the child's school was changed and he was put in another school. And in the other school, this kid joined a peer group that was far more problematic than the one that he came to the school with. So now what would be our diagnosis? Now what would be our understanding of the case? In the sense, how would we understand this child better other than just plain conduct disorder? That is, what are the other facets of this child that we now know? So if we look at it now, we can definitely say that for sure that the child has conduct disorder, that is not in doubt. But the child also has ADHD and the child also has anxiety disorder NOS. Now, the reason why we said anxiety disorder NOS is that there was history of stomach aches, not being able to go to school, not wanting to separate from the grandmom. Now, was it a separation anxiety disorder? Frankly, we don't know enough history for it because the mother was the only historian and the grandmom was no more. We also had a past history suggestive of depression, but again, the mother was not entirely sure. So we have put it, but we haven't actually made it into a diagnosis. There was a childhood onset fluency disorder, which essentially means stuttering. He was of above average intelligence. And in terms of Axis 5, there were plenty of problems. There was lack of warmth in the parent-child relationship, intrafamilial discord, inadequate parental supervision and control, events relating to resulting in loss of self-esteem. Essentially, we mean bullying, loss of a love relationship. Essentially, we mean the loss of his grandma. So if you look at it from the multi-axial, from Rutter's multi-axial diagnosis, we now see that it is beyond conduct disorder. It's not just as simple as saying that this child has conduct disorder. So naturally, whatever intervention we plan has to take into account the fact that the child has ADHD, the fact that the child has an anxiety disorder, has history suggestive of an anxiety disorder, and has anxiety as a trait which continues to be present, did have a past history of depression. So these are things that we can't wipe away, and we can't say that they have no implications. And apart from that, we also feel that the Axis 5, where we have put all the child's various issues, are important for intervention. So coming to Bonfrenbrenner's social ecological model, we see that it is not just the child, it is the child, the environment that the child grows up in, the way in which the environment interacts with the child in depending on the layer of proximity. So for example, the child's immediate family, schooling, all of that have an immediate influence on the child. The culture that the child grows up in has a more distal influence. But that influence is something that is very important for us in order to understand this child well. So coming to another way of understanding this child is the way we formulate the case. And I like to formulate cases like this because it gives us definitive points in which we are able to intervene. So if we look at the predisposing factors, the personal factors, and the contextual factors, the predisposing factors, which are again divided into personal or contextual. What would be the predisposing factors in this child? The predisposing factors would be that the child has a genetic vulnerability to ADHD or externalizing disorders. The fact that the child has a poor attachment relationship with his mom. So those would be the personal, apart from, of course, the child having an anxiety disorder and having a history of depression. So those would be predisposing factors that are important. Dr. Rajendra, could we go to the next slide? That way they can see what I'm saying. Thank you. So if we look at the predisposing factors, like I said, we're looking at a child who has a genetic vulnerability to ADHD. We're looking at a child who has aggressive behavior that is already present, anxiety. So those are things that we will look at as predisposing. Contextual would be the fact that both parents have psychological disorders. There is significant marital discord. We are already looking at a child who has gone through bereavement. It's a chaotic family environment, and the attachment relationship is not really a secure one. And that is attachment to his mom. Coming to the personal factors, what are the ones that maintain this psychopathological symptom profile? One is, of course, that the attachment is poor. We're looking at a low self-efficacy. We're looking at what we call as a hostile attributional bias, which I will come to a little later. And in terms of protective factors, well, this kid is of average intelligence. He has no medical comorbidities, so those are good things. And coming to the contextual factors, we are looking at a pattern of parenting that is simply not conducive to the child developing appropriate coping and appropriate understanding of limit setting. The parental disciplining is poor, it's inconsistent. Inadvertently, they reinforce problem behaviors rather than good behaviors. And the parents' own psychological problems and their own interpersonal discord results in them having less of a bandwidth to deal with the child's problems. So that's again something that we need to take into account. But again, the good thing about this family was that they were willing to accept that there is a problem. They were willing to look at it as a problem and to sort of see how best they can get get ahead by dealing with the issues that they had. Coming to the precipitating factors, the bereavement that he experienced with the loss of his grandmom was a huge stressor. We mustn't forget that he also had a huge change in his circumstances at that point in time. That is, not only did he lose his grandmom, but at the same time, nothing to do with her, of course, but at the same time, his father also sustained a loss in his business. He moved to another school. He lost the stable schooling system that he was a part of. He lost his friend system. So in many ways, it was a complete, sort of disruption of the child's life, which is something that also resulted in the depressive disorder that occurred soon after. So when we look at why children become what we call as bystanders to bullying, or why children passively engage in bullying or even actively engage in bullying with a peer group, one of the things that oftentimes comes to be is that when you are part of a group that bullies, you aren't going to get bullied. Yes, so it becomes where the person is part of a group that is aggressive and is therefore unlikely to be aggressed upon. And that's something that this child probably took with him to the next school, because he did have a lot of bullying experiences in his previous school, although he had a good system of friends, but he had a lot of bullying experiences due to his stuttering. So he must have thought, I might as well go and join a system of people who won't bully me. And the best way to not be bullied is to sort of be part of the group that I suppose, does not bully him, but bullies others. Nothing to say that it is right, but I'm just trying to point out that these are all mechanisms and ways in which children cope. Those are not effective ways of coping for sure, but those are ways in which children cope because they don't know a better way to cope, or they don't have more adaptive ways to cope, or they don't have a system that will support more adaptive coping. So how do these conduct symptoms therefore come to be? These conduct symptoms come to be because there is a set of predisposing factors which interact with contextual factors, which interact with personal factors, and there are a set of precipitating factors that essentially result in this mix, sort of churning out conduct symptoms, which is essentially what I've tried to depict here. Right, so if we now understand how conduct symptoms come to be, the question that I would like you all to think about for a moment is, are externalizing and internalizing disorders mutually exclusive, or are externalizing and internalizing disorders not really as watertight as we once thought them to be? Obviously, the answer is externalizing and internalizing disorders are not as watertight as they once were thought to be. So this is a way in which we understand these disorders, but doesn't mean that nature decides that they will keep it in watertight compartments just because we have divided it in that manner. So to that end, children can have anger, irritability, hyperactivity, oppositionality, aggression, and can also have low self-esteem, somatic symptoms, suicidal behavior. So they can have a mix of the two. Nothing to say if they have this, they can't have that. Yeah, so that's essentially what I'm trying to say, that these are not two mutually exclusive dimensions. These are dimensions that freely mix with each other. And the reason I wanted to spend a moment on this slide is because when we see a child with conduct disorder, the harm that they cause other people is so stark and in your face that you are forced to deal with it. But the troubles and anxieties that this kid himself feels or herself feels doesn't really come to the fore. It's not something that he will tell you or the parents will tell you. And so it happens that nobody deals with it. But that's what fuels further conduct symptoms. So if we don't deal with the internalizing symptoms that the child has, then conduct symptoms are simply going to get worse. Because his pain, how is he going to share it, or how is he going to deal with it? So it's very, very important that when we are dealing with a child who has conduct disorder, for us to look at that child's own troubles and own anxieties and worries, because that's the only way to get the child to kind of deal with the behaviors that he has that infringes on the rights of others, right? Okay, so this is the problem list of conduct symptoms, essentially impulsivity, anger, irritability, defiance, oppositionality, aggression, lying, truancy, difficulty, difficulty with academics, violation of rules, alcohol and other substance use disorders, high risk sexual behavior, suicidal behavior, low self-esteem. So this is the problem list that we are looking at. I have divided it like this, where we look at academic problems, externalizing behaviors, internalizing, and traumatic experiences. But I am not going to talk about internalizing and traumatic experiences. Dr. Rajendra has another set of sessions planned for you. As with academic problems, I just put this here in order for you to understand that these are all the range of issues that have to be dealt with children with conduct disorder, not just the externalizing problems, because that will get you nowhere, right? Coming to academic problems, I am not going to look at it in detail. The next slide. The next one. Yeah. So let's look at conduct problems in general. So when we come to conduct disorder or conduct problems, the model that we are looking at is a chronic care model. It is an NCD model, the non-communicable diseases model. It's the same model that we use for substance use disorders, which is to say that it is not you will provide intervention and everything will magically improve tomorrow, but it is that we are going to have to move this child and family along in a manner where there will be a number of slips, a number of relapses, and the child continues to improve because the support of the system is one which is going to be there at all points in time. Coming to the kinds of conduct problems, you can have transient conduct problems and you can have more long-standing and pervasive conduct problems. The transient conduct problems are essentially seen in those children who have had some serious psychosocial stressor. That could be the loss of a parent, the loss of a loved one, having gone through something like parental divorce, or it could even mean, it could even be that there has been a traumatic episode or incident that the child himself or herself has gone through. So it's usually in response to some kind of a stressor. Which is not to say long-standing they don't have those stressors, but it is just that these have begun after a certain event. With child psychiatry, the dictum that we understand is that all children have some form of comorbidity or the other, especially by the time they come to a tertiary care center. It's for us to kind of figure out what these comorbidities are. So these comorbidities could be developmental, the comorbidities could be other psychiatric disorders. It's important that we take the time to distinguish what symptom falls in what category. Coming to family problems, disorganization, and other psychosocial stressors that may be there at home, that's again something that we often see together, and it is something that we have to deal with. And so if we don't deal with it like that, that is individual and the medical and psychiatric comorbidities and the environmental risk and protective factors, we will not be able to treat the child in a comprehensive and holistic manner. Okay, so to that end, what would we like to do? We would like to look at individual, family, and school, because that's the three main areas that we are looking at. In terms of individual, for this child, we did look at individual therapy, especially grief work, because even after the bereavement of his grandmom, no grief work was done. We looked at the child's understanding of his own difficulties, the way in which he has problem solved thus far, and the coping strategies that he used till that point. So those were things that we looked at in therapy, and those were things that we addressed in therapy. Coming to comorbidity, we did treat ADHD, and we treated anxiety, from a psychological perspective, that is, we use CBT for the anxiety, but even that comorbidity was something that we treated. With respect to the family, a lot of work has to go into psychoeducation, because the parents usually feel that here is a bad apple. Here is a kid who is not good. Here is a kid who is sort of morally deficient, or is not a child who is morally upright. And there is a great need for us to change that perception, because till they continue to believe that this is a problem that the child is deliberately doing, that is, all of his behavior is deliberately provocative, and there is a need for him to do this just to annoy us or just to trouble us, then we're going to get nowhere. So psychoeducation must focus on the parents' perceptions of the child's illness and the ways in which they have understood this illness in order for us to be able to look at treatment. Another aspect that we spend a lot of time with the parents is on monitoring. Now, there are two aspects to monitoring. One is that the child must allow monitoring, and two is that the parent must be ready to monitor and to actually enforce the consequences that they have put forth with respect to monitoring the child. So those are aspects that I will talk about in the slides to come. No doubt there was a need for us to do parental counseling to see how best the parents are able to sort out their own interpersonal difficulties and how we could offer help to them for their own psychological problems. And of course, there is a need for liaison with the school. Now, coming to individual work, like I said, we did treat comorbidity, especially the ADHD. Here, the mood disorder had sort of resolved, so we didn't need to treat it, but it is something that is a significant part of the child's history, because there is a likelihood of him having another depressive episode in the future, or this child turning out to have bipolar disorder. And so when we treat ADHD, there is a chance of a switch, or if we treat anxiety, there is a chance of a switch. So those are all things that we need to keep in mind. In terms of therapy, we looked at what were the problems caused by the child's deviant behavior. We discussed the child's own the places in which he himself has been a victim. And this is something that children will often tell you, that they did 7 out of the 10 things that they were blamed for. But it really, really troubles them when they're blamed for all 10. They didn't do the last 3 and they were blamed for them. And the reason why that is important is that if there is no actual accountability and you're blamed for everything, then you might as well do it all. So in that sense, it's important that we look at scapegoating as an important aspect where the children feel highly troubled. Apart from that, we looked at the child's own bullying experiences and negative experiences that he had gone through. There were issues that needed to be tackled. Those issues included social skills. He had poor assertiveness skills. He felt if someone else was doing it, might as well quietly do it with them rather than say that he doesn't want to do something like that. Self-esteem needed enhancement. We also looked at self-regulation strategies, because a lot of the time he was dysregulated at home, and the dysregulation at home resulted in his parents and his sister being almost scared of this kid. We worked on anger management. So these were all areas that needed specific interventions. And I've forgotten to write here that we did a lot of work with respect to anxiety, because anxiety was what was fueling the other problems. So when he became anxious, it would be that he has an entire meltdown, and that meltdown resulted in him hitting the sister or hitting the mom, and them becoming more and more worked up and worried. We also look to see how he can develop more mature defense mechanisms rather than the immature ones that he was using. One of the things that I want to highlight here is that we must have goals that we work with the child, so that he or she knows what is the outcome of this. Why am I coming for so-called counseling, or why am I coming for individual work with this person? If we don't have any form of a goal that we're working towards, we are looking to see, for example, how can you control your anger this week? Or we are looking to see, so we have some kind of short-term goals, and we're looking to see whether you are able to manage with a set of people without going and doing something foolish, at the same time without flying off the handle. So there is a need for the child to understand, why am I going through what I'm going through, and how should I help myself? How should I put into practice what they are talking to me about? So those are things, because we can't talk about every single situation, you see. We will be able to discuss one or two situations. But for all of these skills to be generalized, the child will have to have an understanding of what is our overall goal and what are the resources at his disposal. And those resources at his disposal can be the child's own internal resources, and could be resources from outside. So, for instance, mental health professionals are one form of external resource. His friends, a good friends group, maybe another. The child may decide to join an art class or a kung fu class. So that is another form of resource. So we are looking at how do we build these resources, both internal and external, in order for the child to develop adaptive coping strategies, rather than to sort of be a bystander and allow other people to do what they want to do and be a part of that group, or worse, actively do things that are simply not what the child originally wanted to do. So those are ways in which we look at it. Coming to social problem solving, I don't know if you remember, in the previous slides we were looking at what were these personal sort of maintaining factors. And one of the maintaining factors we spoke about was this hostile attributional bias. Now, what is hostile attributional bias? Hostile attributional bias is where the child takes an ambiguous stimuli and converts it into a hostile one. So, for instance, somebody is walking by, they step on your foot by mistake, and you say they did it purposely. That person didn't like me, and they stepped on my foot on purpose. And that's an example of a hostile attributional bias, because it is a way in which you make everything that is happening around a referendum on you. And you make it into something where the person feels that all the bad things that are happening are because you are not liked. You are not somebody that the other person likes. So do badly in a test, it is because the teacher doesn't like you. Something else happens, then it is because that person doesn't. So that essentially is hostile attributional, which is found to be a significant problem in children with conduct disorder, where they take these ambiguous stimuli and give them hostile intent, which means that they respond aggressively toward that stimulus, rather than responding in a manner that is far more contained and mellow. And in order to deal with hostile attributional bias, we use a form of CBT, which is to kind of look at it as a cognitive distortion, assess the situations in which it occurs, look at a range of possible reasons why what occurred, look at a range of solutions for those problematic situations, sort of anticipate the impact of these solutions. So it is a mixture of looking at cognitive distortions and correcting those cognitive distortions, and looking at problem solving as a method. The next slide. Yeah. So every time we talk about anger management, it's something that we talk about all the time. But whenever I ask residents what is anger management, they're always telling me it is where you count from. I told the child to count from 10 to 100 to 1,000 to 1. But the fact of the matter is, it is not just about counting. And so if the child understands, when I am angry, I'm supposed to start reciting numbers, it is not what we want. Yes. So what do we want? We want the child to make a distinct sort of separation between what is anger versus an angry response. Telling the child not to get angry is humanly not possible. We all get angry. We all get angry on a daily basis, many, many times. So anger is not the problem, but an angry response which results in the child sort of beating up the mom, beating up the sister, that's not okay. So what a person does when they are angry, that's what we are looking at, and that's something that we want the child to understand specifically. Angry. So therefore, how do I de-escalate? How do I reevaluate the situation and what would be an appropriate response. So which means that we don't want children to respond immediately in the heat of the moment. We don't want that. So which means we oftentimes tell them that, you look at your anger and you look to see how angry are you. So we call that tension monitoring, or whatever way you want. Order to be able to allow your, so yes, please show that. That's what we call as an emotion thermometer. This is especially useful for children who are younger, useful for children who have developmental disorders, especially autism, because it helps them kind of, grade their anger on a Likert, as it were. And so therefore they are able to say, in this, when you are out of control, what must you do? So you de-escalate. When you are extremely angry, what must you do? When you are frustrated and feeling upset, what must you do? And so you have like a way for the child to say, okay, this is how I am feeling. It gives them a way to label emotions. It gives them what we call as a vocabulary to express their emotions. And it also allows them to be given an option for what they must do. We all know that when arousal is extremely high, the frontal lobe sort of is not working at full capacity. So in order for the frontal lobe to again kick in, we want that space. And how do we get that space is what we are trying to do with the kid. So one is, of course, this emotion thermometer. This is another way to do the emotion thermometer, where we say, what do I look like? What can I do? And so again, it is directive. This will help, especially for children with developmental disorders. But for a child who does not have a developmental disorder, they can sort of collaboratively decide with you what they can do at that point in time when they're extremely angry or upset. All right. So, like I said, the first thing that we tell them to do is that when you are angry is not the time that you formulate any form of response, because that essentially turns out to be reactionary rather than where you have processed, where you have understood, and where you know what you are going to be talking about or doing. So to recognize anger, to break away from the action, to de-escalate, check the level of control that the person has, and then only come back to the situation again, rather than to stay in that moment and to make a bad situation worse. And in terms of why, what made me angry? What about what she said made me angry? Why did I get angry? What pushed my buttons? Those are all things that we want the child to be able to process, and therefore then decide how they want to handle it. So for example, we have children who say, when my mother says, you are good for nothing, you're always like this, I have tried very hard for 5 days to not do this, I have tried very hard for 5 days not to smoke, but one day when I smoked, she said, you're always like this, you're never going to improve, you're always going to be like this. That really upset me, and I decided, okay, let it be, I'm going to do what I want. So what is it that the child is saying? The child is saying that the mother's disappointment in the child is what drove his behavior. He couldn't take the disappointment, or he couldn't take her being hurt about his behavior, and that is why he got more upset. So if we are able to deconstruct it for the child, and the child is able to de-escalate, come back and tell the mother, when you say that to me, I feel terribly discouraged. Can you not say it like that? Can you say it like this instead? That way, it gives an action point for the mom as well, and it gives an action point for the child as well. And there is a scope for them to improve their behavior, rather than where they tell each other nothing, and where the child essentially says, I don't want her to monitor me at all, because she often says the wrong thing. And for the mother, it becomes, whatever I say, he takes it the wrong way. Yeah. Okay. This slide I put because when we look at problem solving, we always have that, those few steps for problem solving, saying that what is the problem, identify the problem, come up with a range of solutions, pick a solution, deciding on the pros and cons. Once you pick a solution, run that solution. Depending on what the results of that solution are, monitor it, evaluate what happens when you utilize a particular solution. If it simply does not work, try another solution. So, if it simply does not work, go to plan B. But before we sort of have this problem solving plan, I think we should look at the problem itself. Say, take COVID-19. and we say, children must learn, must study now in school. Okay, but right now it's not safe to send the children to school. So one of the things that we have to accept is that online and offline learning, which is pre-recorded learning, even what you guys are doing right now, listening to me drone on and on, is not going to be as effective as, say, you all had come for a conference here to NIMHANS. It is a live session. You all are able to interact with everybody in a far more, organic environment. Then your learning is undoubtedly better. But this is the situation in which we are in. So rather than saying this is the ideal, we say these are all our limitations. What can we do within these limitations? So the point is that oftentimes parents want an ideal solution, or children want an ideal solution, and it is up to us to say, now that is impossible to do. But can we do this? It's not all or nothing. But can we do these things in order for us to move forward? That's what we're looking at. We're looking to move forward, not stay in the same situation. So those are things that are important to discuss while we are discussing problem solving. Next slide. Okay, now coming to the family. There are a number of things that we want to discuss with the family, including, like I said, the way in which they view the kid. Now, oftentimes there is a view of the child that this kid is a bad kid, and we want to remove that perception, because that perception either comes with a certain amount of fear and the parents simply don't want to engage with the child, or and so therefore the child is given carte blanche to do whatever they want, or the child is basically just pandered to, and that's also not something that we want. So in order for the parent to reassume their position at the in terms of taking reins of their family back again, in family systems theory we often say that those hierarchies need to be maintained for these reasons. I think that the parents need to understand the child as having trouble, no doubt, but not that here is a bad kid. That's not the perception that we want. It's also important for the parents to understand what has led to this problem. So what has led to this problem is not that the child by himself decided to be bad. It's that there were a number of circumstances that have led to it, and the parents themselves have a role in it as well. So which means that there is a need for them to step up as well, get the help that they need, both to cope or to deal with their own psychological problems. And so that is also a big step where they say that they need to take part in the healing rather than them saying, treat my child, don't look at me. Yes. We also need to look at what is the effect of modeling. So if the father comes home and screams and yells at his wife, hits the child, that's not very good modeling. Or if the mother is simply not able to manage her emotions and is all over the place, again, that's not very good modeling. So there is a great need for effective modeling, for lack of this kind of coercion in the family environment. So that's something that we need to look at. Coming to the family coercion theory itself, can we go to the next slide? Yeah, so this was something that was given by Patterson way back in '92. What is coercive family process theory? What coercive family process theory essentially says is that at the core, the parents have a very poor relationship with their children. It is not a relationship which is filled with warmth, where there are positive interactions between the parent and child. Now, on a background of parents not having a good relationship with their children, they punish the children as and when they please. That is, I am in a bad mood, I'm likely to hit the child, irrespective of what the child did. The child may have just done something very, very tiny and inconsequential. As opposed to, I am not able to do something right now because I am preoccupied with something else. Even if the child does something big, I'm going to let it go. So, which means that punishment is not commensurate to the breaking of rules. It is inconsistent. It is based on whims. It is not really based on any form of fairness or any, there is no consistency to it at all. And thirdly, the cycle that maintains the coercion is that they end up reinforcing bad behavior. So an example for this is that the child says that he wants some food item to eat, and the parent says, no, you're going to eat what the mother has made at home. And then the child throws a huge tantrum. He screams and yells and maybe hits the mother, throws the food that she gives him or something like that. And then the parent, makes a Swiggy order. That essentially means that the parent has reinforced bad behavior. That is him asking, saying that I want to eat X, did not get him X, but him throwing a tantrum did. So it essentially reinforces problem behaviors because the parent has acquiesced at that point in time. And that is something that we need to constantly discuss with families as to how they brought about the resolution of a temper tantrum. If the resolution of a temper tantrum or the resolution of frankly bad behavior is by giving in to the bad behavior, then we're never going to solve it because it is going to occur over and over again. Right? Next. So therefore, what are we trying to do in therapy? In therapy, we are essentially saying that the coercive sort of vicious cycle that the parent and the child is caught up in is broken, that the parent develops more positive disciplining strategies to discipline their children, that the form of interaction between the parent and child is not transactional like this, where it is you give me what I want, I will not do what you don't want. It is that there are positive patterns of interaction between the child and parent, and that the parent has the bandwidth to do all of this, which means that actually wait out the child, actually put into place the consequence that they originally said they would put into place, which means that them having a psychological disorder, them not being able to handle their own emotions, them having trouble between themselves is only going to compromise their parenting effectiveness. And that is something that we want to again address in order to be able to be effective parents. Yeah. So this is in the systems theory, which is essentially to say that we are looking at how do we reinstate the parental hierarchy, how do we keep those intergenerational boundaries intact, how do we improve communication styles by not being switchboard but by actually being clear and direct communication strategies, and how do we have explicit rules and routines for the family. Correct. Now we're coming to monitoring. One of the most robust findings in conduct disorder is the lack of parental monitoring, and that is something that we see over and over again. Okay, I'm finishing quickly. I have only another 2, 3, I think 4 more slides. Is that okay, Rajendra?
Madam, definitely you can.
Okay. Like I said, one of the more robust findings that we have in conduct disorder is the fact that parental monitoring is poor. Now, how do we get the child and parent to agree to monitoring? That is by doing what we said previously. That is by resetting the parent-child relationship such that the parent and the child are maintaining their intergenerational hierarchies, that the parent is the person in charge, and the parent develops more positive disciplining strategies. Next. Yeah. So this is a sort of diary that we would often get in our OPD, where we tell the mother, see, I want you to maintain an ABC. I want you to note the time and place. I want you to tell me what happened to cause the behavior that you are talking to me about. What did you do at the end of that? So this is something that we want the parent to share with us in order for us to be able to help the parent design intervention strategies with the for the child that are effective. Next. Yeah. So obviously any extreme is a problem. So a completely authoritarian form of parenting is an issue. A completely lax and permissive style of parenting is a problem. So we are looking at a middle path where the parent is authoritative, where there is a sort of willingness to check the child when the child is going out of the limits that are being set by the parents, and at the same time taking into account individual likes and dislikes, individual temperament, individual choices and wishes. So to that end, can we have the next slide? So to that end, we want um, the aspect of parenting that we call demandingness, and we want the aspect of parenting that we call responsiveness. So responsiveness is to sort of look at the child's individual likes, dislikes, choices, and those kind of things. And demandingness is what we want the child to do in order to fit into society. So those would be to close your mouth and chew when you're eating, or that would be to not be aggressive, that would be to understand certain rules of society. So demandingness is that. So there has to be a balance between demandingness and responsiveness. We don't want to raise sheep. At the same time, we don't want children who are simply unable to take into account another person's feelings or thoughts, who are so self-centered and so self-absorbed that they're not able to take into account other people and their feelings as well. Yeah, so this is more of that. So like I said, there has to be a balance between individualistic autonomous thinking and a certain amount of rule following if we want to live in a society where we are able to respect each other and we are able to sort of live without stepping on each other's toes. Right, now we come to behavioral parent training. Behavioral parent training is a way of us manualizing what I have essentially said so far. And so the way in which behavioral parent training is designed is that we look at how the parent can first develop a better relationship with the child. So which means that we want those positive interactions to go up. Only then will the parent be able to sort of set some limits. So when at this point we say, how can the parent spend more quality time with the child? How can the parent be more interested in the kid? And by doing all of this, we are conveying to the child that we are interested in what he or she is doing, and it is not just the parent is not doing it in order to get the child to do something else. That's not the purpose of it at all. Then we look at a set of behaviors that are okay and not okay. If they are not okay, how does the child curb it? What are the processes that are going to be put in place in order for the child to understand that if he or she does something that the parent does not want them to do, how will they be, for want of a better word, punished? But it is not punishment as such. And this is something that we need to kind of arrive at collaboratively with the child, because any diktat that is put forward is only going to be broken in no time at all. That is, there must be a buy-in. The child must buy into this entire thing. And lastly, we must tell parents that they mustn't keep grudges. You did that last week, you did that the week before that. That essentially means that the child says, well, that is going to remain. Is it an indelible mark? If it is indelible, I might as well not try. So carrying grudges, verbally, physically abusing the child, those are all things that are a no-no for this entire thing. And lastly, oftentimes when we design parenting programs, we tell the parent, you mustn't focus on low frequency behavior, or you mustn't focus on behaviors that are not really very problematic. So for instance, say the child doesn't get up on time, or say the child does not make their bed, or say the child. So here we're looking at aggression, we're looking at those kind of big ticket behaviors. We're not talking about small behaviors, which if the parent spends all their capital on, then there isn't going to be enough for the other big ticket behaviors. Right, next. Yeah, so this we must address. Parental psychological disorders are a big point of intervention, and we mustn't forget that. If we want to treat the child, we have to treat the environment, and the parent is the environment. Right, these are my last set of slides. Here I basically want to talk about a very behavioral way of going about dealing with aggression. In psychiatry, most of our referrals for children and adolescents deal with aggression. That is, parents either bring the child saying that they were aggressive, or schools refer to us saying that the child was aggressive. And so how do we behaviorally handle aggression? There are three ways. One is that we look to see how we can change the antecedents such that aggression does not occur at all. Two is we change the consequences such that aggression is no longer rewarding. And three is we see that aggression need not occur because the child has more adaptive coping strategies. We agree that aggression occurs at the moment because the child has poor coping. So we develop better coping. So to that end, how do we make aggression irrelevant? Like I said, we change the antecedents. How do we change the antecedents? We look to see, is this child doing this for me to provide him attention? Let me give him attention freely. Or is this child doing this because he or she is upset with his sister or brother? So let's see, how do we solve their sibling related issues such that this does not need to occur at all. So you basically change the situation in which it occurs such that aggression is no longer required. I can ask for my parents' attention in a manner that is going to be freely given to me rather than my having to do something to get it. The next slide. If we're looking at how do we make it ineffective, that's where all the limit setting strategies, all the consequences for actions, all the consistency in parenting comes in. So the aggression does not actually get them what they want. So it cannot get them the food that they want. It cannot get them their father's bike. It cannot get them those things. So if it does, then it's going to be fed. And so we want the parents to understand that the more they inadvertently reinforce problem behavior, in this case aggression, the more it is likely to occur. And lastly, we make it inefficient. That is, if I can negotiate, if I can ask my mother, you know what, I want to go out with my friend, and she says no, and I am able to convince her because I have enough negotiation skills, I have better social problem solving skills, I have better anger management, then I don't need to aggress at all because I have figured out another way to get people to be persuaded and to listen to me. So that's why, that's where we make aggression inefficient, because there's no need to aggress in the first place. So that would be it. So in conclusion, what I want to say is that we are looking at a chronic care model for externalizing spectrum disorders. We are looking at this model being something where we have to look at a comprehensive plan. That plan involves multiple systems. It's not just the child, it's the child, the family, the school, and the larger community. We are looking to see how best we are able to intervene at all levels in order for us to treat the child efficiently and effectively.
Yeah, madam. Thank you, madam. So I think, madam, we have done with the presentation. I request the participants that have any clarifications or doubts, they can raise their hand and unmute, and then they can speak, or even they can post the messages. One message is from Sania Ambrin. So the question she has is, how different is hostile attribution from paranoia? So like we consider it to be a primary cognitive distortion. So what is the difference between hostile attribution and paranoia? That is her question, madam.
Yeah, so paranoia is not a cognitive distortion, isn't it? This is a kind of cognitive distortion. So it is where if you ask the person for concrete proof, how much they believe in it, they're unlikely to give you that kind of buy-in into it. So at best, it is going to be an idea that they feel may be happening. It's not the same way as paranoia, where there's a greater buy-in with even less proof.
Yeah, madam. One more doubt is regarding role of medical management in this case.
Yeah. So I purposely didn't actually spend too much of time on medical management, but I will briefly talk about it. With respect to ADHD, there is a need to treat if the ADHD is severe enough to warrant pharmacological treatment. It's very important to remember that in preschool ADHD, there is a very real risk of side effects. So unless the hyperactivity and the impulsivity and the behavioral problems are to that extreme which warrant pharmacological management, preschool ADHD mustn't be treated with medication. As far as possible, you must use psychosocial methods. And one of the best methods would be environmental modification and parent management training. For school ADHD, the short-term efficacy of stimulants, for that matter, even non-stimulants, have been established. It is there is enough proof for us to say that treating school-aged ADHD is with medication is not a bad idea at all. But the long-term effects of that is again something that we don't know about. So whenever we start treatment, there is a need for monitoring. There is a need for asking yourself at the end of every 6 to 8 months to a year, does this child continue to need this medication? Does this child continue to need this form of help? That is something that we need to do. Side effects are something that need to be sort of scrutinized in great detail, because after all, we are dealing with kids. And for adolescents, yes, again, there is no doubt with respect to the efficacy of stimulants and non-stimulants for ADHD in adolescents. But again, one must look at the comorbidity patterns. We must look to see whether this child is at risk for a mood disorder, at risk for other psychiatric illnesses, and the medication that we give mustn't precipitate anything. Or if it does, we should be in the know so that we are able to help the child quickly. So those are aspects of medication which are related to ADHD. With respect to conduct disorder, there have been studies which have looked at atypical antipsychotics for conduct disorder, but treating with atypical antipsychotics alone simply does not have an evidence base. We need to look at a combination method of treatment which looks at psychosocial interventions along with atypical antipsychotics if required, or the treatment of comorbidities with conduct disorder, be that depression, be that ADHD, in order for us to truly intervene in conduct disorder. So for conduct disorder, the medication management is based on the comorbidity profile. If we are using atypical antipsychotics, there is again a need to monitor, especially with atypical antipsychotics, we need to look for metabolic side effects, and we need to look for neurological and neuromotor side effects. Those are all important aspects of monitoring. And again, we need to reevaluate the need every 6 months to see whether this form of medication is needed. Is it warranted? Should it be continued? And if it is continued, what is the sort of basis for us to continue?
Yeah, so madam, next question is from Birva Desai. Like the question is like, many parents demand for some sort of medication during the exam period for improving the concentration or for better memory. So what is the suggestion from you is what they are asking.
Absolutely no. So those are the reasons why people are so worried about the misuse of stimulants, exactly for the reasons like this. Stimulants can't be used to enhance performance. That is simply not to be done. It is to be used only for the treatment of a disorder. It is not to enhance performance. So like I said, that is simply not to be done. Parents may want, that means that we need to spend a little more time in sort of telling them why those are not useful models to take the child down, where everything is based on their outcome. And so we are essentially teaching the child your self-worth is related to the outcome in academics, and that's not how we want to go. What if after this they fail in a particular exam? Then what is to be done? Yes. And if the child is not doing well for any particular reason, there is a need for us to look and see, are we looking at a comorbid learning disability? Are we looking at a child who has difficulty in understanding the subject because of a particular reason? Or we are looking at a global difficulty in understanding. So are we looking at a child who is high functioning but has intellectual disability? So what is it that we are looking at, and why is the child having difficulty? Or is there absolutely no form of instruction for the child? So I think it's important to ask those questions rather than give a prescription.
The next question is regarding diagnostic criteria, where the ADHD criteria has been increased from 7 to 12. So the
Why is that?
person is asking for the possible scientific reason for which it has been done by Challa S.V. Krishnavasan.
Yeah. So the reason why that has been done is that a lot of children who have inattentive ADHD don't get diagnosed because they don't actually reach a class where inattention makes a huge difference. So if we look at 8 or 9, what are we looking at? We're looking at second, third grade. And at that point in time, those symptoms don't come to the fore. So if a person has a predominantly inattentive kind of ADHD, they don't come to clinical attention simply because their clinical problems aren't something that create socio-occupational dysfunction if they're fairly intelligent or if they have enough psychosocial support at home for the academics. On the other hand, by the time they come to the 6th standard, these symptoms will come to the fore, and that's why it was increased to 12 years of age. Yeah, so I hope that answered that question.
There are two brief questions, madam. One is regarding if there is any traumatic exposure to any harsh video content, what can be the therapy and pharmacological approach. It is quite outlining, I mean, not keeping with the today's presentation. But one more question is from Dr. Namita Nazir, where she is asking that even when the ADHD may be not completely syndromal, or even conduct disorder is not completely a disorder, can we start at the earliest, even at the age of 12, 10 years, a therapy?
Absolutely, absolutely. So the good thing about starting therapy or any form of psychosocial intervention is that you are looking at symptoms. You don't have to look at it as a disorder at all. So if the child has aggression, you can treat the aggression psychosocially by all the methods that we discussed today. It doesn't have to be anything that we label, meaning you feel it is subsyndromal. Absolutely. You can follow up the child, you can treat the child with these psychosocial methods, treat the family for the troubles that they are having, all of that. Yes, but medication, that is something that requires great thought. One must have a plan for the future. One must look at monitoring. One must look at what point in time am I going to discontinue this? What is my plan for this kid? Vis-a-vis medication. Those are questions that need to be answered at the get-go. And parents also need to understand what is the goal of medication. It can't be that say I'm treating ADHD and conduct. Medication for ADHD is not going to solve my conduct problems. So in that sense, if they think that just popping a pill is going to solve something else, it's not. So what are the goals of pharmacological management? What are the goals of psychosocial management? Those are things that must be discussed in the at the point when you have your first or second consultation, and then periodically, because these are things that are difficult to understand for us. For a family, it's that much harder.
Yes, sir. So the question from Dr. Pankaj, as I mentioned in prior, was like it was related to the traumatic experience and therapy and medication. So he has asked, like, for 8, 9-year-old, what is the role of therapy and psychopharmacology for any child who comes with symptoms secondary to exposure to traumatic video content?
Yeah, so that's a whole different lecture by itself. But I take your point in that, especially right now when everybody is locked inside the house, there is the risk of children seeing content that is inappropriate for them in very many ways. And so there is therefore a need for us to understand at different levels what we can do. One is, of course, to talk to the child to understand what is it that the child understood from those images or from that content, rather than us telling the child what the image meant. And then to deconstruct it for the child in a manner that is developmentally appropriate, to have good monitoring systems in place, to look to see how they can have those monitoring systems in the system, that is in their phone or in their iPad or whatever it is that they're using, to have monitoring system outside where the child will not use a phone or an iPad or a desktop or laptop all by themselves, that it is in the company of other people. And lastly, to see what is the other offline behavior that is possible. So, for example, is this child getting adequate physical activity? Is this child doing enough chores at home? What is the other academic activities that this child can engage in? What are the other activities that the child can engage in? How can I provide this child a routine and a sort of rhythm to his day or her day? So it has to be an overall uh, like everything, it has to be an overall comprehensive plan of management rather than just this one thing that we do. So there is no silver bullet there.
Yeah. Yes, madam. So I think we have answered, I think, all the questions raised, madam. If any, lastly, I ask any participants if they have any questions, they can post. So yes, madam. So I think we have addressed. So today we have heard the importance of not treating ADHD, but the child behind it, and not just focusing on medication, but nuances of interventions that can be focused with child, with family, and even with the school. So thanks for the presentation, madam. It has been very useful for all of us. And thanks again. I thank all the participants for the participation. Thank you, one and all.
Thank you. Bye.